So good evening, everyone. My study is correlating intraocular VEGF levels with prompt clinical regression of TB granulomas treated with anti-VEGFs and moxifloxacin. Tubercular granulomas are the most well-recognized phenotypes of intraocular tuberculosis. These are hypoxic granulomas associated with increased levels of VEGF. VEGF is said to be a known biomarker for active TB disease, both pulmonary and extrapulmonary. The purpose of this study was to evaluate the intraocular VEGF-A levels in TB choroidal granulomas and correlate them with the clinical regression on treating with intravitreal anti-VEGF and moxifloxacin. The secondary objective being to evaluate the visual improvement in these patients. Ethical clearance and informed consent was taken. 10 consecutive patients with intraocular TB granulomas were enrolled in the study. Aqueous sample was subjected to sandwich ELISA test and VEGF-A levels were measured using human VEGF antibody pair kit test. Intravitreal injection of bevacizumab and moxifloxacin was given every week till the granulomas regressed. Systemic therapy in the form of 4-drug ATT and corticosteroids were continued, and a correlation was done between the VEGF levels and the clinical regression of these granulomas. 10 eyes of 10 patients were included in the study, out of which 8 patients showed choroidal granuloma and 2 patients, they had an optic nerve head granuloma. This is a table showing the decreasing levels of VEGF on subsequent intravitreal injections in these patients, and these tables are showing the clinical regression and clinical response of the TB granulomas on giving these injections of moxifloxacin and anti-VEGF. The primary outcome was that the mean baseline VEGF-A level was found to be 1,000 to 1,500 picograms per ml, which had drastically reduced at the time of last injection to 27 to 50 picograms. A prompt clinical regression was found in all the 10 patients within 4 weeks of starting these intravitreal injections, with an average number of injections being 3, ranging between 2 to 4. At baseline, 9 patients had a best-corrected visual acuity of less than 636, which had improved in 4 patients to a vision of 6.6, 2 patients with 618, and 4 patients with less than 624. This is one of the representative cases of this series, where a 24-year-old female patient with diminution of vision in the left eye for last 5 days and already on ATT for last 2 months for pulmonary tuberculosis. We see a large TB granuloma supranasal to the disc and also involving some element of the disc with cystoid macular edema in the macular area. At baseline, the VEGF-A level was 927, which had drastically reduced to 422 after 1 injection. This patient apparently did show a very good response of the TB granuloma, but developed a paradoxical reaction, which was treated with IVMP and stepping up of the oral steroids. This is the timeline of this patient, where the vision had improved from 636 to a complete recovery of 6.6 N6 vision at 2 weeks follow-up, with a total regression of the TB granuloma. This is another representative patient where you have a large TB granuloma involving the macular area. The VEGF levels measured were 1200, which had drastically reduced down to 257 after 2 injections of intravitreal moxifloxacin and anti-VEGF, and the vision had improved from 3/60 to 618. So TB granulomas are hypoxic granulomas with increased VEGF-A levels, which are said to be 4 to 5 times higher than that found in AMD CNV patients. Patients with active pulmonary TB are found to have VEGF levels in the range of 700 to 800, while AMD CNVM patients are said to have it in the range of 100 to 200. The half-life of intravitreal bevacizumab is said to be between 2 to 7 days in non-vitrectomized eyes, but it further reduces because of the breakdown of the blood-retinal barrier secondary to inflammation in these eyes. This is a representative cartoon of a TB granuloma, where you have caseation necrosis in the center surrounded by macrophages, which are harboring the TB bacilli and surrounded by the abnormal vasculature. And what this abnormal vasculature does around the granuloma is that it leads to unequal distribution of the ATT drugs, reducing a multi-drug therapy to a monotherapy, and thereby increasing the risk of multi-drug resistant TB. Hypoxia also makes the MTB bacilli dormant, and as we know, INH is the only bactericidal antitubercular drug, but it does not act on the dormant bacilli, and it acts only on the actively multiplying bacilli. Thus, the need for innovative host-directed therapies. And what an anti-VEGF does, it decreases the hypoxia and thereby avoids the bacilli from becoming dormant and increases the bactericidal effect of INH indirectly. It also normalizes the vasculature of the granuloma, thereby increases the small molecule delivery of ATT and thereby decreasing the development of multi-drug resistant tuberculosis. Now, what is the role of moxifloxacin? It accumulates in the activated macrophages which harbor the MTB bacilli with a higher intracellular to extracellular concentration in comparison to other ATT drugs, and thereby helps in elimination of the MTB bacilli from the macrophages. The VEGF levels were measured for the first time in this study in patients with ocular TB granuloma. An effort to normalize the vasculature of the TB granulomas is done as quickly as possible so that the ATT drugs effectively reach the granulomas and regress them fast. It was a proof of concept study and hence the small number, and it was a non-randomized study and thus the limitations. So we conclude by saying that very high levels of VEGF are found in patients with tubercular granulomas. A monthly injection of anti-VEGF may not be enough to aggressively treat these vision-threatening TB granulomas. Weekly intravitreal injections of anti-VEGF and moxifloxacin given as an adjunct to ongoing ATT and steroids may help in faster regression of these granulomas. I would just like to acknowledge the contribution of National Institute of Immunology, which helped us in measuring the VEGF levels, and Professor Amod Gupta for all our knowledge on ocular tuberculosis. Thank you.
Thank you, Manisha. Would you like to?
Thanks, Manisha. Nice study. Just wanted to know, so basically VEGF is secreted in cases of tuberculosis by the macrophages.
Yes.
And they secrete this VEGF. The purpose is to cause new vessels.
Right.
So that the immune, all the cells go to the tumor or to the granuloma to take care of it. Now you are blocking this VEGF. Do you feel that ATT may not reach enough now, because that's the only path through the blood, it is going through these vascularized channel? It is there in all other parts also, lungs also, they say that ATT activity reduces.
So that's a very valid question, but what we need to understand that because of the high VEGF levels, it's not the normal vasculature. It is actually the abnormal vasculature which is developing around the granulomas. And the abnormal vasculature is not having a normal structure. So rather than actually helping in the healing or in the distribution of the drugs, there have been histopathological studies which have shown that it hampers the equal distribution of the ATT drugs. And therefore, despite being a multi-drug therapy comprising of 4 drugs, it actually reduces being just a monotherapy. And that is what is the main underlying cause of multi-drug resistant TB, which is developing so rampantly in our patients. So that's really not something which is useful, which is happening in these.
VEGF, how you feel would be helpful in the clinical care? Because we know that definitely VEGF is more, even in pulmonary.
Right.
It will be much more in the ocular one, because of a vascularized granuloma.
Right.
What clinical implication this will have?
So, till now we never had the concept of treating these ocular TB granulomas with an anti-VEGF drug. This was just a proof of concept study where we wanted to highlight that the VEGF levels are much higher in comparison to our routine patients of AMD, CNVM. But what you say is the clinical implication. All you know, in future it may act like a biomarker just to assess what is the activity of the disease still persisting when you're not getting a good response to your drugs.
You said you have to give the anti-VEGF every week.
Yes.
So how practical is it to give a anti-VEGF every week? And for how long do you have to give it?
So again, that's a very valid question, because being retina people, we are very used to giving a monthly injection, and that's what we all are used to. But the difference being over here that these are the patients who are not requiring more than 4 injections. And we have been now regularly treating in our clinics every week, and we see a beautiful regression of the granulomas. And why I want to suggest this is because if we are allowing a regression of these granulomas just to take place on systemic drugs like ATT and steroids, what we have been doing as a standard of care, the time taken for the regression is about 2 to 3 months. And it already causes so much of RP atrophy and scarring that the visual recovery is hardly there. The advantage what we are getting over here, even though we are treating them very aggressively by giving an every week intravitreal injection, is that the regression is taking place within 2 to 3 weeks. The limitation is that it's not an indefinite treatment that you'll continue for months or years. It's just requiring 2 to 3 injections, a maximum of 4. And in 95%, the regression will take place within 4 weeks of your treatment.
Rather than giving every week, can you think of a higher dose? Because if you give if we know the maximum concentration is
Right.
within a week, and we know in sometimes of neovascular AMD, we give a higher dose of anti-VEGF.
Sure, that's a good idea. Maybe we can explore
And
it
you're
in the
also
future.
documenting a lowering of the VEGF levels with the anti-VEGF. So don't you think you could wait a little longer before repeating the injections?
Ma'am, as I mentioned, we are in a great hurry because we want to even increase the efficacy of the ATT drugs, which is getting hampered by these abnormal
And what
vessels.
is the systemic ATT protocol that you're following?
We are using the 4-drug ATT for 2 months and then followed by 2 drugs.